I was first made aware of BWS in the late 1990s when Dr. Michael DeBon came to the National Cancer Institute, and he was a young, fiery, energetic young oncologist who was really focused on doing something for Beckwith-Wiedemann syndrome. And he put together a team of physicians and technologists at the clinical center here at the National Cancer Institute to really try to make progress in this disease and really understand it better than it had ever been understood before. So one of his first missions was to design a database in which he acquired data about patients who were thought to have Beckwith-Wiedemann syndrome and put it all in one place. And of course, sometimes people have good ideas that never come to fruition, but Michael knows how to get things done. And very shortly, I was receiving hundreds of images from around the country from patients who were affected with BWS. And we were starting to compile, and we really started to learn a lot at that moment about what the disease was, what it wasn't, and to understand how to classify Beckwith-Wiedemann and separate it from other overgrowth syndromes that were lookalikes but weren't really the same thing. So those early years were really exciting, and we really made a lot of progress, and we started seeing patients here at the clinical center with Beckwith-Wiedemann and started to follow them and learn some of the real nitty-gritty aspects of doing screening for this disease, and that's how I first came to be aware of it. I am a diagnostic radiologist, and I don't do treatment so much as do early discovery of problems. So I see my role in this as using our sophisticated imaging tools to discover the target lesions that occur with Beckwith-Wiedemann at a very early stage. Now, one of the good things about it being a pediatric disease is that it's amenable to ultrasound. And ultrasound, as you may know, is very easy to do in children. It doesn't require sedation. There's no radiation. It's relatively quick. And we've assembled a team of really expert people who know how to deal with children and get really good quality imaging from even squirming young kids who really don't want to be there. But there are other sophisticated techniques in the department like computed tomography, CT, and MRI that sometimes we have to go to solve some of the problems that we pick up on the ultrasound. We're not quite sure what those findings represent, and so we have to go on to more sophisticated types of imaging techniques. So my role is really to tell the oncologist or the surgeon what is going on in a particular child, whether it requires immediate attention, whether it's something that can be watched, or just something that's an incidental finding that we really don't have to worry about. And that's really my role. So early imaging of children with Beckwith-Wiedemann syndrome is critical because it enables us to detect the lesions at the earliest stage possible. Some children are even born with tumors at the time that they're born, and it's important to get baseline studies on the children. It's not just imaging, by the way. It's also blood tests that have to be obtained when the child is born, and they are very, very important for detecting some of the early tumors, like some of the liver tumors that can occur early on. So it's very critical that the child get entered into a screening program very early in life and keep to that program for the next 8 years. So they become pretty expert at having ultrasounds and very familiar with radiology departments by the time they're 8 years old. In fact, some kids and parents find it hard to give up on the screening after 8 because they've gotten so used to coming to the department and getting good news and reassurance that's kind of hard to give that up. But it is really much less necessary after the child reaches a certain age. That's one of the good things about Beckwith-Wiedemann syndrome is it is a syndrome that you kind of outgrow in some respects. We do a very systematic check of the internal organs with our scans. It's almost like like a pilot doing a check before taking off. We look at all of the organs in the abdomen and get a good look at it. So we'll look at the liver, we'll look at the spleen, we'll look at the pancreas, we'll look at the kidneys, and we'll look at the tissue deep to all those organs, what's called the retroperitoneum and the adrenal glands. And we do that in a very systematic way. So the first thing we want to do is look at the size of those organs because, as I mentioned before, Beckwith-Wiedemann is an overgrowth syndrome. So one of the first things you notice is that the organs are bigger in some of the kids, and that puts the kids at some increased risk for developing tumors. So we look at the size, and then we look for any evidence of a mass or some abnormality. Now, what we've noticed over time, looking at many hundreds of images, is that there is an increased rate of benign things that happen in the abdomen too. So not every finding is a tumor. And you have to carefully look at what the individual lesion is, what its characteristics are, sometimes going on to some of these other modalities like computed tomography and MRI to figure things out a little bit more. And in the end, come to a conclusion about whether this is something that needs to be treated right away or something that can be watched for a later time. And so that's sort of the general procedure that we go through, and we do it each time, every time, no shortcuts, over and over for these screening studies, every 3 to 4 months.